Laura Cranston, PQA's Chief Executive Officer, has led PQA since 2006. And over the course of that time, she has led 29 national PQA meetings. This will be her 30th PQA meeting, and as many of you know, her final meeting as PQA's CEO. So during the next session, Laura will share thoughts on COVID's impact on quality and pharmacy services. She will then lead us in a timely fireside chat on the impact of the crisis on care delivery and the businesses of PQA's membership. So without further ado, Laura, please start us off at the 2020 PQA Leadership Summit.
Thank you, Lauren, for that introduction. And I would love to add my welcome to the 2020 PQA Leadership Summit. I'm pleased that more than 400 individuals from across our member organizations have joined us to discuss the social determinants of health and participate in an action-focused meeting as PQA looks to develop an SDOH research guide next year. SDOH has been a priority for PQA and for our members for many years. We know that addressing the complex circumstances in which individuals are born and live is important to advancing medication use quality and helping individuals achieve the health outcomes they want and deserve. I can think of no better individual to initiate today's dialogue with than Dr. Jain, who serves as president and CEO of SCAN Group and SCAN Health Plan. A nationally recognized innovator in healthcare, Dr. Jain joined SCAN this past summer, where he is focused on pioneering new ways of improving quality and maintaining affordability for older adults. Dr. Jain has held key positions in the life sciences industry and with HHS, where he served as senior advisor for the Office of the CMS Administrator, part of the founding team at the Centers for Medicare and Medicaid Innovation, and part of the senior leadership at the Office of the National Coordinator for Health Information Technology. Dr. Jain, thank you so much for joining us today. I remember it's been probably 4 or 5 years since I read one of the articles that you authored on social isolation and loneliness. And one of the things that impacted me the most was that you referred to the negative impact of social isolation and loneliness as equating to smoking a pack of cigarettes a day. I also remember that back at a health plan that you were at before SCAN, you hired the nation's first Chief Togetherness Officer. And we had the privilege of meeting that individual, and you gave that person free rein to develop a new program to begin to address loneliness as a disease. So my question for you today to get us started is, what were some of the measures that you used to look at the impact of that program, and what were some of the lessons learned that you've taken with you to SCAN?
Thanks so much, and it's great to be here. I will say the journey on solving loneliness is one that we're, I think, in the first or second inning of really a 9-inning battle. But one of the things that we looked at in the assessment of our togetherness program, led by our Chief Togetherness Officer, was our rate of hospitalizations as well as readmission rates. And what we found is that, individuals who were part of our intervention group ultimately were admitted to the hospital less and were readmitted to the hospital less. And we believe that that was a function, first and foremost, of the fact that having someone in your life, having some connection to someone who cares about you, leads you to care more about yourself and leads you to ultimately take better care of yourself and engage in preventative screenings more, and ultimately manage your chronic diseases better. Because much of our desire and our motivation and our will to live is grounded in our connections with others. And I believe very strongly that the healthcare system needs to do more to create more connections with others.
Here we are in 9 months into this pandemic, and I can speak with an 81-year-old mother, my mom in New York, who is isolated. And we see that across the country. So as a health plan exec, how are you addressing social isolation during the pandemic, and how different does that look compared to pre-COVID?
So we've I think, redirected many of our staff to really do wellness checks on our members. And one of the, I think, big ahas of doing this work now for a number of years across a few different settings is the realization that, for a variety of reasons, there are many people in this country who don't have anybody. And so the very act of calling in and checking on individuals and making sure that they're doing okay is a very meaningful act. It's something that doesn't happen enough for people. And for many of our seniors in this country, it doesn't happen at all. And so we have a group of seniors who actually we have on staff. They're actually SCAN members who help our patients actually navigate the care system and navigate their health plan, whose efforts have been redirected to do wellness checks on lonely or socially isolated seniors. And, ultimately, I think one of the most amazing things about this problem of loneliness is that it doesn't require us to invent a new medical procedure to solve. It doesn't require us to pioneer a new, medicine or a vaccination. It requires us to just direct our will at actually solving the problem. And we have a huge workforce of people who are ready to solve this problem, which is the 300 million Americans in this country, who, if they decided to connect with each other more, to pick up the phone, to go visit, could actually be part of solving the problem today. And so I think it's a big obligation of people who are in positions of leadership in healthcare to redirect the efforts of their folks just a little bit to make sure that there is this sense of civic spirit and connection to others that can actually really make a big difference.
So did I hear you correctly, though? Did you say you have SCAN members who are doing check-ins with other SCAN members? So are they volunteers?
No, they're actually paid employees of SCAN Health Plan. And they are, their job is to help folks navigate, the SCAN system of care. And, but, as the pandemic struck, we realized that this was an incredible workforce of individuals who would be able to, I think, do important work to check up on some of our most frail and socially isolated patients.
Wow, that's very impressive. So when we think about the infrastructure that you have at SCAN is so unique. SCAN started as a social HMO demo back with CMS, and it was called the Senior Care Action Network, I think in the early 1970s. So you've really been at this for 40 years, maybe a significant jump start on others. How have you built the infrastructure inside of SCAN over that period of time to really coordinate the social needs and the healthcare needs of your members?
So it's a great question, and I want to kind of go back to one word in our founding name, Senior Care Action Network, which is this word action. I think there's so many organizations that talk about social determinants of health, that opine about it, but ultimately this theme of action is so critical to our culture and who we are as an organization that we've actually built a set of processes end to end that really focus on this issue of ensuring that we're asking people about the social determinants of health and then doing everything we can to intervene upon them. Part of our intake forms and intake assessments for our members is a social risk assessment where we ask patients about how hungry they are. We ask them about whether they have challenges accessing medical care because of transportation. We ask them about whether they're lonely or socially isolated. And then we look at the suite of resources that we have, our set of benefits, our care programs, and then we actually match people who have needs to those benefits and to those programs. We also have a wide array of community partner organizations that we actually work with. And so recognizing that we can't solve all of these problems by ourselves, we can't do this alone. And so I think it's that focus and that attention that was part of the founding intent of SCAN when it was founded by 12 angry seniors who were upset about the broken status quo around senior care in this country, that I think continues to guide our program development and our approach to problem solving today.
One of the social determinants of health that's getting increasing attention these days is digital access and digital literacy. So during this pandemic, we've seen so much healthcare services delivered, telehealth, telemedicine. How do you begin to address digital access and digital literacy in the midst of this pandemic?
Yeah, it's a great question, and it's actually leads me to mention a new benefit that Josh Good, our Chief Information Officer, ensured that we introduced to our benefits, for the year 2021, which is actually access to a help desk to help seniors navigate using the tools and technology that are in their lives. Oftentimes, we have computers, we have iPads, we've got tablets, we've got phones, but we don't necessarily have the skill or digital literacy, so to speak, that guides us on how to use these tools and technologies. And so one of the filed benefits that we actually filed with CMS was access to this tech help desk that ultimately supports people in using these tools and technology. We got early exposure to the need for this during the pandemic, when we had a number of folks who didn't necessarily have what they needed to access their care virtually. And we have countless stories of members who call and say, I need help setting up an email address for the first time, because you actually need an email address to access many online digital tools and technologies for your health. And so we're helping people with things as simple as how do you set up an email address. So it's been particularly gratifying, and it's been a great to be part of finding solutions to serve the people that we serve.
That is great. I didn't realize you would have to file for CMS for a service to offer a service like that, but that's very cool, very innovative. Wow. Hey, I want to switch topics for a minute. And when I went out before COVID in January to visit Scan Health, one of the things that was so impressive to me was the way you utilize community health workers. And that's part of the infrastructure that you've built to address SDOH factors. How has that worked for you? How do you use community health workers differently than maybe another healthcare professional? Can you talk a little bit about that?
Yeah, I mean, I think we sometimes overbuild programs, and we require too many certifications and too many degrees for to ultimately accomplish what I call radical common sense, which is this idea that people who care can actually solve problems for people who need solutions. And at Scan, we were recognizing that you don't always need a nurse, you don't always need a doctor. Sometimes what you need is a neighbor who actually cares about you. And so we have one of our implementations of community health workers is something called Connecting Provider to Home, which is where we actually send community health workers into medical office appointments with patients who sometimes don't necessarily understand the instructions that they are being given, don't necessarily have the health literacy that they need to manage through a health situation. And they need someone who can actually be the fabric between that medical office appointment and the instructions that they're given in that medical office appointment, and then making the changes that they actually make in their lives. And we found that it can be an incredibly important kind of intervention to offer patients with complex illnesses and multiple problems. The added navigation of a community health worker can be the difference between adherence, which is, I know, a big theme here, for all of us at PQA, and non-adherence. And so, I think the challenge is, of course, making sure that we're intervening upon the right patients, because you can create a lot of waste in the healthcare system when you provide solutions to people who don't need them. And so a lot of the work that we have to do, I think, as a healthcare system more broadly, or as a country, is figuring out where the resources are best applied, because we don't have unlimited resources.
Right. I could not agree more with that statement. I want to switch gears for a minute. You've also written a lot about the intersection of quality, underserved populations, and Medicare. And I just want to take for a minute, you recently tweeted, and I am not on Twitter all too often, but I actually saw this one. It says, "We need to acknowledge the pernicious effect rating systems such as the Medicare star ratings have on disincentivizing healthcare organizations from serving underserved communities. You said it's one of the biggest challenges to health equity in an increasingly pay-for-performance world." So I wanted to ask you, if you would, to go backwards. You spent significant time here inside the Beltway at CMS and HHS and ONC. If you were, now that you have these lived experiences as a CEO of 2 health plans, What would you go back and tell your peers in the administration and CMS at HHS about how these plans are maybe not aligning incentives appropriately? What could we do here inside the Beltway?
Yeah, it's one of the reasons I believe that government needs a constant influx of people who've actually operated in the real world. And I think it's all about being aware of the unintended consequences of the systems that we create. I think everyone has the best of intentions. Everyone who worked in the quality measurement world has the best of intentions. But if you create systems that disproportionately reward performance without necessarily acknowledging the challenges of achieving that performance in a particular population, you end up pushing organizations, nudging them in the direction of actually serving people who are a little bit easier to serve. So, here at SCAN and previously at CareMore, our performance is governed by the Medicare STAR system, and the differences, in payment between achieving 4 and 4.5 stars or 3.5 and 4 stars are remarkable. It's between $50 and $100 per member per month. Over a year, that's more than $1,000 per member if you're talking about a swing between 3.5 stars and 4.5 stars. So the rewards are extraordinary. Now, if it's easier for me to achieve those rewards in a simpler to serve population, of course, the rational operators would ultimately focus their efforts on growing in communities where it's easier to achieve those rewards. And so I think the challenge we have to kind of overcome is ensuring that we're not creating disincentives to serve communities and patients and populations that may not be as easy to reach. People who maybe for whom English is a second language, communities where the provider networks aren't necessarily quite as sophisticated. And so I think some of these ratings and ranking systems have this incredible effect of creating disproportionate incentives to serve easier to serve populations. So I think we have to take a hard look at that. And organizations like PQA, through their government relations and lobbying efforts, I think need to take a leadership role in nudging federal regulators and policymakers to consider these unintended consequences, even as they're building programs to raise the bar for everyone.
I don't disagree, and well noted. I'd love to have a CEO roundtable of health plan execs come to Washington or participate in a Zoom call and share this feedback directly. I'm sure that they would be interested in hearing it. We certainly we certainly try to carry that message whenever and wherever we can. I totally hear you on that one. But speaking of tough populations to manage, I have to address the homelessness situation because you're living it every day in cities like LA and San Francisco, and I'm from New York City, so whenever I go back home I see it. And I recently read an article, it was back in March in JAMA, and it talked about whether or not CMS should create a homeless special needs plan. And I'm just wondering, your thoughts as a CEO of a California health plan where you walk out on the streets and you see it every day. How can we meet the needs of this population that is so unique?
Thanks. Yeah, I wrote that article in collaboration with John Backus, who leads LA Care, as well as Jim O'Connell, who leads Boston Healthcare for the Homeless. And I think all of us believe that one of the challenges to how we think about homelessness is that we're not necessarily thinking about a total cost of care perspective. Many seniors, many homeless individuals or individuals experiencing homelessness actually are Medicare eligible. And many of them incur very significant healthcare costs because their primary means of access to the healthcare system is the emergency room. And access to behavioral health and addiction treatment, which are two big problems in the homeless population, are quite challenging. And so, I fundamentally believe, I think all three of us fundamentally believe, that one of the biggest opportunities we have to attack the homelessness problem at its roots, which is oftentimes a healthcare root, whether it's medical conditions that predispose you to homelessness or medical conditions that arise because you are homeless, is actually working to build a better healthcare delivery model. And so we're actively reorienting many of our efforts here at SCAN to ensure that homeless individuals who could benefit from a program such as Medicare Advantage have a program
Wow.
and a plan that's very closely tailored to serve and solve their needs. And it's something I know that the SNP Alliance is actively engaged in advocating for. And I've been fortunate to share this concept with Seema Verma, the administrator at CMS, as well as Brad Smith, the head of CMMI. And I'm very optimistic that I think we can align the energies around this to actually create a solution for one of society's most significant and frankly most embarrassing problems. We're in 2020 where we have unprecedented wealth in this country, and yet we have individuals who are lying on the streets and who are uncared for. And I find it morally reprehensible and something that's totally unacceptable and something that we have to build, I think, real policy solutions to solve.
A quick question as we close out our conversation. PQA is the Pharmacy Quality Alliance, and we think a lot about the role that pharmacists can play as we emerge from this pandemic and as we look to address these social determinants of health. So when we think about medication access, adherence, appropriate use of medications, what do you envision as the role that pharmacists can play to address some of the social determinants that impede access to medications?
Ultimately, what I can say is I believe that the scope of practice for pharmacists needs to be expanded. And I think that this pandemic is a great opportunity for us to test that. My own experiences with pharmacists at CareMore was that they are some of the most thoughtful, most organized, most engaged professionals in the care of patients. And I'm very biased because some of my best friends are pharmacists, people like Lloyd Myers, Rena Acharya at CVS Health. And so, when I think about them and their capabilities, I believe that they should be doing more. And I think that, we should be thinking about what part of the care journey could be owned by pharmacists. And I think things like chronic disease management, I think ordering and administering some of our preventative care measures, vaccinations, all of that can be, well managed and well oriented through pharmacist collaboration with other healthcare professionals. I think a lot of what the nurse practitioner field has undertaken on behalf of patients could, in fact, also be absorbed by the pharmacy profession. And so I would say we should be looking carefully at what pharmacists might be able to do in a new healthcare system.
Well, we would welcome that conversation at any time with Scan Health, because we believe too that pharmacists are uniquely positioned out there in the community and can be doing so much more, and that's really what they want to do. And during this pandemic, we've practiced at the top of our license, and we've been given all these emergency use orders that have come down from on high from HHS. And really our goal is to make sure that some of the things that we can now do during this pandemic, we'll be able to do once this pandemic is over.
Absolutely. I mean, we have an extraordinary pharmacy department led by Sharon Jawar, and I think we're always looking for new ways to think about how pharmacists could influence and impact the care of patients. And I think one of the things we're looking at right now is actually pharmacists playing a far greater role in care coordination going forward. So stay tuned for more from SCAN on this topic, because it's something that we're very passionate about here.
Yeah. Well, thank you. And I want to thank you for sharing those insights today, and looking forward to working with you and Sharon Jawar. We really appreciate having her serve on our board of directors. It's very helpful for the overall strategic direction of our organization. But wishing you the best, and looking forward to seeing how you can continue to impact your colleagues back here inside the Beltway at CMS and HHS as we engage in these really difficult conversations. So thanks for being with us today.
Thanks so much. It's been a real honor.